constipation,
Preparing for it. What's that mean?
preparing for a procedure, a surgery or something. Impaction.
About to deliver a baby.
You know, they're getting away from that, but yeah, prior to delivering a baby. And why do they do that?
So that you
So
don't
you
poop
won't
on
have a
yourself.
movement on the pleasure.
Why you pushing? I've
And
had
then
that happen.
afterwards, you can, since you're irritated and all this, you can kind of heal up a little bit before you have abrasion and stretching.
That's right.
Where they're getting away from it?
Oh wow.
Oh.
Oh wow.
You don't see many enemas given prior to.
Like I had one for my daughter, but I didn't have one for my son.
Yeah, I heard they just let you go and, wipe it
Well,
away.
think about if you have a full colon, is that going to further block the passage of the baby being able to get out? Yeah.
I pooped when my son was coming out. And my husband wouldn't let me forget it.
I'm not sure, but I think that if I were a female, I'd go with the enema.
Right.
It's just that whole concept messes me up.
Yeah, I had to, I went before I had her. I wouldn't do so. I was like, I do not want that happening. That would be so embarrassing for me.
Can you think of any other reasons why?
Female?
No, I mean just in general enemas.
I'm playing with it.
I know. I'm recording. So, it's all good.
Fecal transplant.
Ooh, good one. What was that? Say that to the group.
You could be treating C. diff with a fecal transplant, and that's when they take an enema and they slurry up donated feces from like a family member, and they stick it back inside of your colon so that your colon can redevelop the normal flora.
The normal flora, yes.
Well,
Very good.
what about their impact?
And usually they do take a family member.
I see it on Grey's Anatomy.
No, I'm not talking about just as a reason to use the enema.
Do what?
If they're impacted or whatever.
Impacted, yeah. I think
Where said that?
Oh, you said
Aisha said that. Kind of thinking along the lines of treating the C. diff, do we ever administer something like an antibiotic?
for C. diff?
No, into the colon?
Yes.
Yes.
Suppository? Would you do it that way?
We can do suppository, but they can do an antibiotic solution. Go right to the source, right? It's like a topical. They can do that.
For the ulcerative proctitis, they have the saline enemas for me.
So that's a medicated enema. That's right. So it's great, and you probably still will take systemic medications, but to have something directly at the source, it's kind of like patients who have a bladder cancer. They will go in and instill a chemotherapeutic agent right inside the bladder. So you get it right to the source. Okay? Now, when we give an enema, there are several things you need to think about. We have several different reasons for administering them, and there's several different tonicities. This is where you're going to have to pull back what you learned in anatomy and physiology. Have you heard the terms isotonic?
Yes.
Hypertonic?
Yes.
And hypotonic?
Yes.
Okay. Carrie, you're yes.
Yes.
What
Mr. Malkowski.
What is isotonic?
Isotonic has the same level of sodium or inside and outside. Like the solution that is, in this case it would be an enema, the enema solution would have the same sodium level as your body would, so that there's no diffusion across the
Right, so when you administer
osmosis.
an isotonic solution into the bowel, it's going to stay in the bowel,
Yes.
right? We're not going to be pulling water into the bowel, and what's in the bowel is not going to be moving outside the bowel wall, right?
Okay.
Do you think that's the safest option?
It depends on what you want the end result to be.
Right, exactly.
In terms of electrolyte imbalance, is that our best option?
Yeah.
Yes. Okay. There are isotonic solutions. And when we look at solutions, we can have what is called a low volume solution, which is like a Fleets. And we'll bring a Fleets in next week. You can go get it. We have, yeah, go get a few.
And
got the mannequin.
A fleet's enema is about 133 milliliters. So that's not much, is it? It's in a little bottle. For a pediatric fleet's enema, I think it's only 67 milliliters.
Oh, wow.
So when we instill that into a patient, is that going to go throughout the entire colon?
Probably not.
Not very well. Huh? It's more lower part of the colon. So that's a low volume. There is such a thing as a high volume. Can anybody tell me what they think a high volume solution would be?
The gallon bag.
It's going to be a subsets would be a good example. But usually with the enema bag, it's about 500. The bag will actually hold 1,500. So think about pouring yourself a glass of Coke from a 2-liter bottle, and everything but that glass is going to be going into you. That volume. Not the Coke, huh?
Hold it in.
But that volume. Okay? That's a high volume. What can you see as the benefit of a high volume over a low volume?
Clean it all. More area.
It's more area. What is it going to do to, okay.
Gonna liquefy it.
Everything out.
This is a,
That's a freeze.
yeah,
Right.
exactly right. These are just over the counter. They're different colors. See how you have the yellow one and the blue one, and there's an orange one. They have a tube about that long, and they're pre-lubricated with a water-soluble lubricant. And I'm going to pass these around so you can feel how soft the bottle is. And it's designed that way so that when we instill the solution, it's easy to collapse the bottle. You can take the bottle with the heel of your hand and roll it and instill the solution. Why would we not just squeeze it?
It'll suck it back in.
Right, as soon as you let go, it'll suck it back out into the bottle, which defeats the purpose, doesn't it? So I'll pass that around. And here's the little pediatric one.
Mr. Collins said he was going to do a live demonstration on the enemas.
Live demonstration on a student?
No.
Correct.
You see.
I'll need 2 volunteers. One for the enema, the other one to hold them down.
Okay, this is an enema bag.
It's already pre-filled, right?
It's not
Awesome.
pre-filled. You fill it.
Good deal.
Huh? We fill it. When you look at the bag, it's just a bag that has calibrations on the side, 500, 1,000, 1,500. Okay. This doesn't have to be exact. It can be a guesstimate of volume. So what temperature of solution would we put in here?
Room temperature, maybe?
A little bit, really about 105, because we don't want it so cold that it causes cramping, and we don't want it so hot that it's
Perfect.
going to burn the patient.
Okay.
Okay? When you put put the solution in here, and this is just tap water, people. Doesn't have to be a sterile solution because we're not going into a sterile environment. Right? It has like a little rigid collar in here, and you just open it up and you just fill it at the sink. Okay? Doesn't have to be exact, but make sure before you fill it, there's a little clamp on the tubing. You want to make sure that you clamp this off. All right?
Otherwise it'll drain all out.
Huh?
Otherwise it'll drain all out.
It'll drain all out. Now,
Very quickly.
very, very quickly. The end of the tube has a cap on it, and this comes pre-lubricated. You can kind of see it looks kind of hazy. Comes pre-lubricated with a water-soluble lubricant, and the end of this tube has a hole in it, and it also has a hole on the side. Why do you think it has 2 holes in it? It kind of diffuses the exit of the fluid. So we're not going in one place. It's going to cause the patient's colon to spasm more readily. Also, do you think you might get some fecal material plugged in one of the holes?
Mm-hmm.
Yeah, and then that would totally defeat the purpose. We wouldn't be able to administer the enema. Okay.
Where is the patient sitting at the time that you're doing this? On the toilet?
Laying on the side. Usually they're going to be in bed on their left side.
And you got pads down to catch
You're going to put a Chuck's pad up underneath the patient. And Mr. Collins is bringing a mannequin around.
Excuse me, it's pointed
Okay. Why would we put them on their left side? So they can push blood pressure.
Because that's where the colon is. I mean, that's where the sigmoid is.
The sigmoid colon goes down this way. So we don't want to fight gravity. We don't want them on their right side, and then we're instilling it and expecting it to go upward. It's not going to. So we put them on their left. We call it a Sims position, and they're in. It's also called a semi-Fowler's. I mean, semi-prone position. Semi-prone position, because they're on their left side, and then their right leg is going to be crossed over the body, kind of like this, right? And that's going to open up the buttocks. You see how that is? And then we would instill it. Before we get there, I'm kind of jumping ahead of myself. You're going to keep your patient covered. Now, we're going to come back to this. You know how when you did a sterile dressing change, each of you probably had one component of the skill that you felt like, wow, I needed to practice that a little bit more. There's going to be one of those with enemas. And that skill with the enemas is operating this clamp. All right? This clamp is a great tool to have, but can you see how cumbersome it is to try to crimp off the tubing? It almost takes two hands to do that. Best thing you can do, crimp your tubing. You see how easy that was? When this solution starts flying all over the bed and you're freaking out because you didn't practice the clamp enough, crimp it off. It stops. All right? You're going to learn a lot about gravity with this skill. Also, and we can get an IV pole, and usually we're going to put it down at the end of the bed. It's nice to have this. You're going to get it, so when you hang your solution, has anybody read up on it and know how high the bag needs to be?
18.
Very good, Joe. 18 inches above the anus. So, and that usually if you raise the patient to your waist height, which is a good working height, once you hang the bag, if it's about your shoulder height, that's about 18 inches. Okay? And that will end up being about 18 inches above the patient.
Why 18 inches, y'all?
Because if it's any higher, because the higher it is, the faster it comes out.
Faster it flows. The lower it is, the slower it flows.
Terminal velocity.
Why would we not want to go fast? Go ahead and get it over with.
You don't want it coming out of their nose.
Cause cramping too, right?
It's going to cause a lot of cramping.
Is your colon meant to just be blown up like a balloon in one little section? No, it's not. So you're supposed to instill it.
So that could cause weakness of the walls leading to diverticuli.
They're going to start screaming.
Okay.
They're going to start saying, "Let me out of here. I can't hold anymore." And if they can only hold this much because we went really, really fast, the patient's not going to benefit from the enema, right? So we put our warm solution in here about 105 degrees, and Joe mentioned, I think it was Joe who mentioned soap suds enemas. Shay? Shay. So with the soap suds enema, an enema kit will come with the bag. It'll come with a Chuck's pad to go up underneath the patient, and it'll come with a little packet of soap, liquid soap. So once we get the water in here, then we add the soap. And you just kind of knead the bag and work the bag till you get it mixed up. Why can't we?
Right.
Yeah, we don't want to administer bubbles to our patient. All right. Now, the doctor may write an order, suds enemas ×3, or until clear. And you will see that SSE ×3, or until clear. What does that mean to you if you are reading that order?
3 times.
You can give it, do we have to give it 3 times?
No, if it's clear after the
No.
first time.
Or until clear, that's the key. So we can give it up 3 times. Why can't we give it 4 times?
Soap suds, it's going to irritate them.
Irritation,
Take away the good bacteria too, right? I mean, does it clean up the?
it will. What else?
You could break down the tissues.
Hmm?
You only ordered for 3 times.
He only ordered it for 3. Why didn't he order it for 5 or 6? Why didn't he just order soap suds enemas until clear?
Excoriation.
Can the patient get into electrolyte imbalance?
Oh, yeah.
Mhm.
Especially with soap suds, because I'd be pulling a lot
And
of
you
stuff.
see, every now and then in the newspaper, a little elderly wife kills a little elderly husband by administering too many enemas.
Mm.
You know, are the elderly obsessed with their elimination habits? Does she think she's doing a good thing for the patient? Unbeknownst to her, the patient's in severe electrolyte imbalance and he goes into cardiac arrest. Okay? So there is a reason why we only do up to 3. Now, if the patient's going to surgery, which is oftentimes when they get soap suds enemas ×3, they're going for a procedure. What if we give 3 and we're still getting solid results back? You notify the physician. Dr. Smith, Mrs. Jones has had 3 enemas and she's still, and then let him make the decision, what are we going to do with this? All right? How long do we have to wait between the enemas? What would you think?
I think at least a half hour.
That's pretty reasonable. About a half an hour. Wouldn't you say, Mr. Collins? And the thing is once we instill this enema, we're going to let the patient get up, go to the restroom. Are they going to be in there a few minutes?
Oh, yeah.
Right. They're going to be there a few minutes. So realistically, about the soonest we can give a second one is about 30 minutes. If I give 3 enemas, can I use this same bag over? Yes. Yeah. Just wipe off the end, re-lubricate it with more KY jelly, refill it, and we're ready to go again. Okay. How would you prepare the environment in the room before administering an enema? Privacy, that's probably the number 1.
Make sure it's
The temperature is comfortable,
Maybe lower the lighting.
maybe.
Make sure the path to the bathroom is open.
Excellent.
Yeah.
Make sure the pathway to the bathroom is clear. So if the bathroom's over there and I'm administering his enema, I'm going to have his bedroom slippers and his robe on that side of the bed. Because when you read your textbook, it'll say administer the enema and then have the patient call you when they're ready to go to the bathroom. Are you going to get to leave the room?
No.
I've never been able to. Usually they're like, I gotta go, I gotta go, I gotta go. And it's a race. You know how slow these beds go down,
Oh, wow.
all right? So yes, get them safely to the restroom. If you know they can't get to the restroom, we want to be prepared with a bedside toilet. They may go on a bedpan. Can you imagine that would be tricky business? Yeah. If they can get up, that's your best bet. What if we have a patient who's incontinent? Do we have to give an enema?
Be ready.
what's going to be happening is it's going in.
It's coming out.
It's coming out. So what might we have to do?
Have a bed.
Right, Lauren said the correct answer. You might have to administer the enema with them on a bedpan. So they'd have to be in a backline position.
We in our PPE, right?
It would not be a bad choice. Put on your PPE. Now, we only have 5 more minutes, so we're going to just talk a little bit about the rest of it. When you get ready to give the enema, I've got my pathway clear to the restroom. I've got his slippers. I've got the room warm. I've got privacy initiated. He's going to feel pretty self-conscious, isn't he?
Mm-hmm.
So I would tell him, Mr. Jones, we got an enema for you today, and if they're really constipated, they're going to be willing to have this to relieve their constipation. But my role with him is I am his coach. I am his cheerleader for this procedure because I need to give him confidence that he can get through this. So I'm going to wear, like Nancy said, my PPE, definitely clean gloves. Okay? And before I give this, I have to make sure I purge the line. What does purge the line mean?
Get all the air out of it.
Get all the air out of it, because last thing I want to do is instill air into my patient.
It didn't say air enema.
So how are you purging it?
Fleets enema or
What
soap
you would do
suds
is either at the sink when you fill it up, you go ahead and I'm holding the tip up here. I uncrimp it, all right? This isn't going anywhere until I lower the tube, right? So I'm going to let it purge, lift it back up, cap it. I'm going to go ahead and crimp it off for right now. I've got my patient positioned in the left sideline position. Now, when you insert this tubing, how far do we go? A little further.
2 inches.
Usually it's about 3 to 4 inches. You get past that, and Mr. Collins, you'll want to check what this new book says, but usually it's 3 to 4 inches to get past that internal sphincter.
Y'all realize you have 2 sphincters, right?
Yeah. You got the external and then the internal.
If you don't get inside the internal, you just like, it'll just come right back out. Okay, you'll know.
All right. So 3 to 4 inches. I've got it lubricated. You're going to go in and you're going to go in the direction towards the umbilicus. All right? What systemic condition in this patient do I need to be paying attention to?
His heart rate.
His heart rate. Why is that?
Because it could stimulate the vagus nerve.
Stimulate the vagus nerve. All right? So you're always watching your patient, talking to your patient. Once I get the tubing in 3 to 4 inches, I've still got this clamped off, right? I'm going to use my dominant hand here. I always take my other hand and support the buttock cheeks. Kind of give them a little support. You're holding it, I'm holding it. You're always going to keep your hand right there. Can they push it out?
Yeah.
They could.
What's the natural tendency, as a
To
matter of
push it
fact?
out.
To push it out. Okay, and it will.
So you're holding this in place. I'm going to open up my clamp. As soon as I open up my clamp, the solution starts going in. At that point in time, I'm going to take my bag here, and I'm going to hold it. Why am I wanting to hold it?
So you can control.
Right, exactly right. So I can control it. So Mr. Jones, and I'm going to be giving him a play-by-play. You let me know if you start having any cramping. Take some nice deep breaths, and you'll be breathing with your patient. If he says, I'm cramping, I can lower the bag. That's going to slow the flow of the solution. Okay, I slowed the flow. You take some deep breaths and let me know when you're feeling better. I'm feeling better. I can raise the bag a little bit. Okay. Mr. Jones, you're about halfway finished. You're doing really well. You start screaming, take some deep breaths. panting breath. It's constantly up and down. If I get to about 100 cc's, he says, I can't take any more. Am I going to say, sure you can?
No.
No, we're going to stop it at that point in time. He says, I can't take any more. I say, okay, I'm going to cramp this off, and then we're going to pull the tubing out. When you pull the tube out, hold the buttock cheeks together, because what does that sensation create of that tubing coming out?
That you want
The need to
go.
push.
That he's going.
Yeah.
He can't differentiate this from fecal material. So I tell him the tubing sliding out may make you feel like you're going.
Now, excuse me, Ms.
Go
Cole,
ahead.
y'all really think lifting that bag up and down makes a difference?
Yes.
It does.
Huge
You will
difference.
be amazed if you just lift it up 6 inches, how much faster it'll go in, depending on what the enema is being used for. But it's amazing. You never let it below the anus. Why?
Because they're back into the bag.
It'll gravity flow and it'll come back.
And I've never seen a return flow enema, have you?
No.
But there's one called a return flow where you just administer back and forth. I mean, electrolyte-wise, it's a good thing, but aesthetically, it's not pleasing at all. And if you have any solid material,
Everything gets clogged up.
it's going to get clogged up. But next week, bring your enema bags. They come in a little cardboard box, about 5 by